I'm Bernard Gersh at EHJ Today. With me is Dr. Tony Gershlick and Stephen James, and we're here to discuss the Culprit trial, just presented earlier today by Tony. Now, Tony, the Culprit stands for what?
Complete versus Lesion-only PRimary-PCI Trial.
Now, but the U in it looks like a V.
Yeah, because as an educated man like yourself will know, Bernie, that the V is the same as a U in Latin, and so it allowed me to use the verses.
There was a politician whose name I won't mention, who went to Latin America on a official visit and said, if I'd known I was going, I would have remembered more Latin from school.
Yes, exactly.
So
that's why. So it allowed me to use the verses.
It was a trial of multi-vessel angioplasty, primary PCI, versus a conservative approach. And just to outline it for us briefly, please.
So basically, patients were, it's an open label study from 7 UK centres in which patients with STEMI were randomised after angiography to either getting the treatment for any incidental non-infarct-related artery stenosis or just doing the infarct-related artery. So you either opened up the occluded right or LAD or circ, or you were randomized to doing the occluded artery first, of course, opening up the artery, and doing the non-infarct-related artery stenosis during that admission, preferably at the same sitting.
Preferably the same sitting, but during that admission. Yeah. And can you just set the stage? I mean, I think it's a very important trial, but I think it's important to bring out why it's so important.
Okay, so as you're well aware, many of the guidelines, the recommendation isn't that you do complete revascularization.
In fact, it's a class 3.
It's a class 3, but of course they were based on many registry data, much of which are flawed by the fact that patients are selected, and of course we know about cardiogenic shock, and we know that patients need total revascularization. And that meant that patients in these registries who were sicker are more likely to have complete revascularization. So only 14% in the Hannon data got complete revascularization at the time, and they were the sicker patients. So maybe they didn't die because the complete revascularization, maybe they died because they were selected to have it because they were sicker.
Stephen, you've had a lot of experience with registries, and my impression is exactly that, and also in regard to the meta-analysis, and that is there are confounders, and given that primary complete multi-vessel revascularization is a class 3 indication in the guidelines, why did these people get, why were they treated that way? And it must be because they were sicker. And
I couldn't agree more. I think this is a very important trial. I want to congratulate you for having performed it and conducted the trial, because I think for such a complex issue, it's really impossible to draw conclusions from observational studies. Yet that was the only we had when we wrote these guidelines. So we really need randomized prospective trials to try to sort this out. So I think that's great. And I want to pass on a question, because there was another trial recently published and presented, also from the UK, the PRimary trial, also pointing in the same direction. We'll talk about the results later, but what was the difference between these two?
They were different in a number of ways. Culprit was independently funded, independent CTEU, and you had to start the, you were randomized during the PCI to the occluded artery in Culprit, whereas in PRimary you did the Culprit vessel and then you were randomized. So I think there was less selection in our study, and also we had a very high incidence of significant stenoses in the non-infarct-related arteries. So more than 80% of patients had greater than 70% stenosis. So they're similar in many ways. They ask the primary question, what do you do when you're presented with multivessel disease? But they are different and distinguished in many ways.
Tony, I also got the impression that there's a difference in the conservative arm, and in PRimary, as I recall, they only got revascularization if they had, quote, refractory angina. I think those are the terms that were used. In your trial, just quickly define the conservative arm before we get onto the results.
The conservative arm was, of course, the hard endpoints. We had a very robust definition of AMI, recurrent AMI, because we didn't want to just revascularize or actually measure just the enzyme bumps. We had to have readmission for heart failure, and revascularization had to be on the basis of ischemia-driven revascularization.
Okay, but not refractory angina.
Not refractory angina.
So the results?
The results showed that the composite MACE at 12 months, as I said, of total mortality, hard endpoint AMI, hospital admission for heart failure and ischemia-driven revascularization, there was a 55% reduction if you treated both the infarct-related artery and any stenoses in the non-infarct-related artery compared to treating just infarct-related.
During that hospitalization?
During that hospitalization.
Stefan?
I think it's a very important message, and there is a signal here. You know, unfortunately, this trial and as well as the PRimary trial are both, they have their limitations in terms of course, size and number of events. Of course. So I'm not sure. Do you think that we need to change our guidelines based on this trial?
I think the use of the words "a signal" is very important. I mean, we can't get away from 2 studies showing such a major difference. And although the numbers are small and therefore not significant, if you look at the composite endpoints of Culprit, the only study I can really talk to, there's at least a 50% reduction in all components, and the reduction in the hard endpoints, and we've done an analysis for AMI and heart failure and death, is significantly different between the groups. So it's not driven by revascularization. So this is, so it's telling us something. Now, these are 2 smallish studies. Both are powered appropriately. We know that because we've got significant results. Although small studies, there's always an issue. I don't think it's time to change the guidelines. But you know, if a physician sees a tight stenosis in a major vessel, then he may question whether it's better to treat that during that hospital admission than not, based on these 2 trials.
Tony, why not change at least soften the guidelines? I mean, right now it's a class 3. Why can't we make that a 2B, because a class 3 is a class 3.
Well, I agree with you totally, but it's difficult because obviously I'm the PI of this trial, and one has to put it into context.
Well, let's ask Stefan. He's not the PI.
Personally, I think that the guidelines, I think what this, just to finish, I think what they're telling clinicians is that there may be a different clinical paradigm for these patients. And we'll leave it to our guideline committees to decide whether or not it's a recommendation.
Stefan, you're unbiased?
I agree. I think we can't ignore. These are 2 prospective randomized trials, and all trials that have to be open label. So they will always have those limitations. And so there are 2 randomized trials going in the same direction with a pretty strong signal. And so I think we should soften the guidelines, really. Going from 3 to 2B, I think that's reasonable because it may be considered. Based on these results.
After all, the class 3 recommendation in the guidelines is based on registry studies. So I would certainly, I think that this is guideline changing. I think it's an important trial with all the limitations. I'd like to end as with, like all good trials, they generate new questions. And the question in my mind is, you have talked about the same hospital admission, and I think you've made the point, and it's positive. Yeah. What I still don't know, or I don't think what we don't know, is what about the same, at the same setting, multi-vessel PCI at a single setting versus a staged procedure? Okay,
so this is the difference between PRimary. PRimary, you had to do them all at the time. For us, we said we definitely have to do them during that hospital admission, but if you felt clinically it wasn't the right thing to do, you could defer it to later on that mission, and 59% had it at the same time. And the reasons for that, Bernie, was that we didn't want patients to have second puncture. There would be much more crossover because patients would have had their artery treated and wouldn't want to go back. So there are all sorts of issues. Trouble is, of course, these were physician decisions, and I think we should leave it to physician decisions. I think physicians are very good at making decisions. And you have 2 a.m. and the patient, my patient who was deferred, I can remember quite clearly, it was 2 a.m. The patient was lowish blood pressure, wasn't so good, had been randomized to complete. The team were tired, and I said, we'll bring the patient back. They have to have it during the hospital admission as part of the trial. We'll bring them back. And we brought the patient back and we did the circumflex heart.
Stefan, we'll give you the last word. Would you still do a plan or think it's reasonable to do another trial of single setting versus a staged procedure, or would you accept, which I think seems very reasonable, that we would leave this, we leave it to physician judgment?
I think the way you did it is important, because when I'm doing a primary PCI in the middle of the night, I have a complex infarction. I'm not really intended to go for a second artery. Maybe that may put the patient at a great risk, so I may want to postpone it to another day. But fortunately there is an ongoing large trial.
With respect, it doesn't quite answer the same question, because it's staged versus nothing. Whereas I think the idea of doing it in hospital, remember that we have an analysis that goes out to 30 days and the p-value is 0.055. So events are happening within the first 30 days. The lines separate early. You come back in 2 months' time, you may have missed the event.
Right, so you're going to do another trial?
Yeah, we'll do another trial, and we may use the taste type registry randomized trial to do it, make inclusive of the UK, and it will be a set of 2 questions. One, is the eye good enough to assess the non-infarct related stenosis? And I think FFR has to have a role there, particularly as we've heard from famous today. And also we need to think about, without too many arms, just how we're going to stage it versus doing it in hospital. In hospital versus stage FFR driven.
And not necessarily single setting versus staged, or maybe?
I think that is no longer for me an important question. We have CMR and MPS data, so we can give you some mechanistic data subsequently.
Congratulations, really good trial, and one whose time was very appropriate, I might add.
Thank you.
Thanks, Tom.
Thank you. Thank you to our audience.